we'll cut a piece of stockinette or liner. It's important that the bandages and foam are over a liner for a couple of different reasons. Firstly, it's going to help everything last a little longer because the liner is much cheaper than the foam and the bandages, so you can always toss this. Secondly, it's going to be more comfortable on the person than having foam, which is basically plastic, on their skin. This at least is cotton, and it'll feel nicer. Alrighty, always cut more than you think you'll need, and I'll show you why in a sec. Okay, the next thing you're going to do, or maybe not, is toe bandaging. So I'm going to show you guys, I'm showing you guys the works. That goes for everything, even this morning. Like, you know, when we're doing our manual lab and everything, I'm showing you everything, and then as you need to modify it, you will. So I'm going to show you how to do a toe bandage, assuming that your patient has toe swelling, and then I'll show you what you would do if your patient has toe swelling, but you don't have time to do a toe bandage. So let's start off with the toe bandage. That's what these little bandages in your pack are for, toes and fingers. So what you do is you bring it around. I'm not really giving this, I'm only giving it enough tension to keep it taut. I'm not pulling on it at all. You anchor around the arch of the foot, bring it over the top of the foot, take your toe, wrap around twice. You want to make sure when you're looking from behind that the bandage isn't down in their crease of their foot right here, but just slightly above, because otherwise that's going to get in there and drive them nuts. When you bring it around over the arch again and onto the next toe. You'll notice I didn't wrap the pinky toe, and that's because wraps don't stay on pinky toes. They're too small. They're too small and adorable. And anyways, to be honest, they don't tend to hold as much swelling. So this could be a fine thing to do. So we're wrapping each toe individually. Again, I would say in my inpatient life, of the people who need this done, I do it on about half, and the reason being is time constraints, you know. But there are some patients that, no matter what, you have to do a toe bandage, and those patients are patients with fungal infections. You need to keep those toes lifted and separated in order for the fungal infection to heal. So, again, every time I'm coming back over, I'm not going over the same spot because I don't want it to feel like there's a bar underneath your foot. And it shouldn't feel tight. Like I said, we're not pulling tight, but we're just preventing the return of more fluid into the foot here. So once you have them all wrapped, if you have some extra bandage, you can just lay it down on itself, or sometimes what's nice to do is running it up the leg, because it kind of anchors it up even higher. If the bandage starts to come loose here and come out the bottom of the foot, your patient will go nuts and they will never let you bandage it again. So that's your toe bandage. The next step then is your foam and padding of the bony prominences. So we'll start with our cotton. The bony prominences being, of course, her malleoli here, the top of her foot, you know, where it's the bone is very superficial, and the knee if you're doing an above the knee wrap. So you can just grab your cotton, and rest down right there. Wrap it around there. You don't have to put too much on. Tear it and stick it to itself. Let's just say your person had a wound here or sensitivity. You can always put a little bit here, anything like that, a little bit under the knee. With someone very active, who's going to be articulating their knee a lot, that can be nice to help it feel softer. Then you grab your foam. With these foam rolls, it's very easy to get good coverage on the leg. So if you've done your toe wrap, then what you're going to do is start your foam roll here. So the base of her foot is still getting some coverage. If you haven't done the toes because of time constraints, you want to bring it up a bit higher. So maybe up there. And kind of get a little bit more compression in like that, because that way the foam, when you wrap over top, the foam will be giving the toes a little bit more compression. Okay? So there's no stretch in the foam. There's no give to it at all. So what we're just doing is going to unwrap the foam roll onto the leg. Now, it's, because it doesn't comply perfectly with the leg, you're going to see a lot of kind of gaping areas of foam like that. Don't worry about that, because what will happen is as you bandage, you're going to bandage those into place and conform the foam a little bit more. So even though it looks messy, it's fine. The main thing you want to avoid is getting a big hole, like something like that, because that's an area where the swelling can escape, and then you run the risk of your patient getting blisters. So just make sure that you're covering everything. And if you get big baggy parts like that, just fold them over. Your bandage will get to them eventually. Most patients need a roll or two of foam, or 3 for the leg. Up to 3 for the leg. If you're very lymphadenosus, they can need 4 for the leg. So you can continue up like so. A little extra here, so I'm just going to put it over the knee again and tuck or tape. Alright, so take out your bandages and have them at the ready. You have your 8s, your 10s, and your 12. So of course we know we always want to start with the narrowest bandage we have. So that's our 8. So we're going to start here at the foot. And I'm going to teach, the way I'm going to teach you guys how to bandage is the way that I teach caregivers how to bandage. So that way, when you're telling your caregivers how to carry this over at home, it can be more user-friendly. So the things we want to do is get more layers distal to proximal. So I'm going to start with my 8 centimeter bandage. I want to go nice and low at the foot so that we're getting the ball of her foot, but I'm anchoring it diagonally so the end doesn't peek out. Okay, so what we're going to start with this bandage, the 8 centimeter bandage, is 3 layers. So that's 1, 2, 3. Once I get to 3, I'm going to move up an entire level. 1, 2, 3. Up again an entire level. 1, 2, 3. Up again. 1.5. So already we have a compression gradient. We have 3, 1.5, 0. So that's how you're going to remember your gradient is by the amount of layers. Oops. 3, 1.5, 0. So then you grab your next bandage. And we're going to start again at the foot. Four, 2.5, 1, 2, 1, 2, and half. So you see 4, 2.5, 2, and a half. So again, the gradient is more distal to proximal. Now, if I was truly wrapping this leg, Serena's leg here, I could, and if I was only wrapping it to the knee, we'll say, I could stop here. But for the purposes of demonstration, we're going to keep on going. Okay, so our next bandage, another 10. Anchor at the foot. 5, 5, 3.5, or, yeah, 3, 3, 1.5, and 1. So we can see that the gradient is still going up, and we're over the knee at this point. So we'll say we're treating for swelling to up to here. So I'll stop there. Again, with a bigger leg, a lymphodematous leg, you would be using your 12 centimeter and maybe even another 12 centimeter after that. But this is sufficient. Does that make sense so far? So after you've done that, you're going to talk to your patient all the time. How does that feel?
Feels great.
Yeah, does it feel tight?
No.
Yeah, it shouldn't feel tight. It should feel resistive.
Right.
But it shouldn't feel tight. And it shouldn't
feel tight or uncomfortable at all.
Yeah, and I mean, with your patient with edema, like I said,
It's kind of supportive, actually.
yeah, it should feel good. Yeah, because it's basically like me just holding up your skin for you. So, have a feel the foam. It should feel pretty consistent, all the way up. The patient should be giving you good feedback. Feel the toes at this point. Make sure that like you felt them at the start, and you're feeling them again. If they're like, freezing now, you're like, oh, maybe I need to like slacken off a little bit. Make sure that you can get your fingers in around it so that they have, enough room around their foot. And then like you can encourage them to what I call break the bandage. So, bring your ankle up and down, bring your knee, because at first they're going to be afraid to. But as they move, it's going to get easier for them to do it. So stand on up there for me. Again, it's going to take a bit of getting used to for them walking in it and breaking it down. But your patient should be able to move around. They're just going to feel a little bulky for a few days, or while they're using this treatment. Okay, so you guys can see that's a basic kind of breakdown there. I started her second bandage at the toe, not at the ankle, and the reason I did that was because her leg is a little shorter and smaller, so I want to get more go out of my bandage. But you can also start the second bandage at the ankle and go to the knee instead. Either way is correct, because either way you're going to get a good compression gradient.
So it's not that there's a prescribed number of turns. It's that it's going to depend on how many wraps you're going to end up using to get the coverage that you need to get.
Yeah.
That you're going to decide as you go.
Yes.
How many turns to do to make the appropriate gradient.
Yeah, you're always going to be making more distally, but like if I'm wrapping you, we'll say for knee replacement, and I know I want to go up to here, and I've gotten up to there on my third bandage or whatever, then you can add more or take away, as you see fit. But yes, as long as you're starting and making more pressure, and like I said, the gradient doesn't have to be perfect. It doesn't have to be 5, 4, 3, 2, 1. It can be 4, 3, 1, 4, or 5, 3, 2, 1, like whatever.
Okay.
As long as it's graded,
Okay.
you're gonna get the results you're looking for.
And as long as you start with the 8.
And as long as you, I mean, if that's what you have available. Now, if I was working in a clinic and all I had was 10s,
Yeah.
that's what I'd
use that the whole way through.
But if you have varying widths of bandage, you want to use your narrower ones at the distal areas.
Okay.
Yeah.
And then how long would I wear this?
So, because this is not a compressive force, and because it is merely a resistive force, what's going to happen is your leg is going to start to decrease. The girth is going to reduce. And because it's not compressive, this is going to get looser. So as your limb reduces inside this, it will probably lose effectiveness over max 3 days. 3 days it should be changed, probably 2 days ideally, if you're expecting rapid reduction, like for someone will say with a knee surgery. You would expect rapid reduction. So then you might want to be thinking every 2 days. However, that's where if you're dealing with someone with a more chronic problem like CHF, actually no, CHF isn't a good example because they tend to reduce fairly rapidly too. But someone with a more chronic problem like CVI, you can be thinking probably 3 days they'll get out of it. But this is also where your liner comes in. I said to cut a little extra when you can. So if I'd wrapped her to the knee, I would leave this liner poking out at the top. Or even if I was wrapping you to the thigh, we cut a piece of liner for poking out over the top. What your patient can do, if it starts to feel loose, because that's going to be irritating, they can grab the liner and pull up. Can you feel how that feels when I pull it up?
Mm-hmm.
Feels a
Yeah,
little
like whole
tighter
thing's
inside.
cinching up. Yeah.
The whole thing cinches. So that can give the patient a lot of relief, like pulling up a sock that's been slipping down in
Yeah.
your shoe. So that way you can sometimes get an extra half day out of it. Yeah, but like I said, I mean, you guys are lucky in the fact that you're all working, or like you're all coming from similar facilities. So what I would recommend is getting a really good communication line in order. So let's just say, you know, Neelam is seeing someone and she's going to do edema she's seeing them 5 days a week. She's going to incorporate edema management 3 days a week. Maybe the first day she gets them so the OT takes all the bandages off and wraps them up while they're in the shower. Neil sees them right after that, does her thing, rewraps them. Then the PT takes them off 2 days later, or like Neelam says, hey, you're seeing you're seeing Mrs. Jones today. Can you take off the bandages towards the end of your session? That'll save me some time, you know, and so on and so forth. So you can be clever. If you communicate well with each other, you can really save a lot of time. Or you can say like, you know, I'm going to be to your nurse. You can say, I'm going to be taking off their bandage at 2 o'clock. If you want to come in and do skincare and take a picture of their knee at that point, you can do it then. You know, that way you're kind of working to your best possible advantage, and people aren't taking them off, you know, and undoing your work, so to speak.
And if there is that fluid coming up through the skin?
Great question. So, lymphorrhea. This lymphorrhea responds almost immediately to this. You're going to have great results with lymphorrhea, because the problem with lymphorrhea is that there's more pressure on the inside than the outside, so it pushes whatever is small enough to come through the skin, it pushes it out. So what you're doing with your bandage is equalizing the pressure on the outside, so the lymphorrhea cannot seep through the skin. So max, you might have to do it twice before it stops. Max. Usually only once will solve the problem. That's another good reason to have your liner though, because you'll toss the liner if there's lymphorrhea on it.
Yeah.
But yeah, lymphorrhea responds super well to bandaging, as you would kind of, you know, as makes sense.